welcome. Thank you for having me. I'm Elena Manning. I work at Beth Israel. I am a podiatrist, so I'm part of the Department of Surgery. I do foot and ankle surgery through Beth Israel. I practice in Quincy, Dedham, Boston at Boston main campus, BIDMC. That's also where I operate. And I also work with the residency program there, so I get to train residents in surgery as well. So thank you for having me, and we're gonna kind of just go over some pathology that we see in the foot and ankle as we get older. I think the goal here is to really talk about what we can do about kind of that pain and how do we keep moving, because that's the key in life, is to keep moving. And also things to watch for. I think our feet are kind of a window into our overall health. It shows symptoms of cardiovascular disease, diabetes. I mean, a lot of systemic issues or diseases we can actually see manifest in the foot and ankle as well. All right, so aging feet. How do we keep moving pain-free? A little bit of my background. I am actually a Massachusetts native. I grew up on the South Shore, and then I went to undergrad in California, and then I came back to the East Coast a little bit, went to Temple for my medical training, and then did my surgical training in Cambridge at Mount Auburn Hospital. I've been with Beth Israel for now 3 years, and prior to that I was at an orthopedic group. So as I said, I treat foot and ankle pain, both surgically and non-surgically, but I am a specialist of foot and ankle. So common foot and ankle issues that we see: arthritis. Arthritis is common as we age. It's wear and tear of the joints. But there's also a lot of foot and ankle deformities. And when we say deformities, we mean bunions, hammer toes, which are more prevalent as we age as well. Tendinitis can also plague a lot of patients of mine that cause pain along the medial aspect of the foot, the lateral, so you have like Achilles tendinitis. And also plantar fasciitis, we'll touch base on that as well. Neuromas are basically pinched nerves in the foot that sometimes you'll hear about, as well as gout. Gout is something prevalent in the foot. It usually affects the big toe joint, but I've also seen it in the ankle joint. And other systemic issues that manifest in the foot are type 2 diabetes, poor blood flow, venous insufficiency or varicose veins, which can turn into venous insufficiency, neuropathy, which also can lead to balance issues, decreased bone density we'll touch on, as well as skin and nail changes. So arthritis. Arthritis can develop in any joint in our body. It's associated with basically the wear and tear of the beautiful hyaline cartilage in our joints, and that cartilage allows nice free motion in the joint. But as that cartilage kind of diminishes or wears down, then you hear bone on bone, because on x-ray it looks like the bone is sitting on the other bone, and we've lost that nice cartilage gliding surface. Other types of arthritis are autoimmune arthritises, so you hear about rheumatoid arthritis, psoriatic arthritis. This is a slightly different etiology where basically your immune system is attacking the joint. But either way, either osteoarthritis or like an autoimmune arthritis, you're having pain in the joint and recession of that cartilage. And so typically we see these more as we age, and they can cause a lot of pain. So what can we do for this? So in the foot and ankle, first we can modify activity, but at the same time we want to keep you moving pain-free. That is the goal. So the goal of really treating arthritis without surgery in the foot and ankle is support the joint or limit the demand of the joint. And we can do that with custom orthotics or bracing for the ankle. Wearing a rigid, stiff-soled shoe can basically limit the demand through the joints of the foot, so then the pain could be less. Anti-inflammatories, anything from ice to ibuprofen. There's also topical Voltaren, which is now over the counter, and it's essentially ibuprofen in cream form for a lot of patients that can't take maybe ibuprofen, Motrin because of other medications. If you're on a blood thinner, you should not be on any or be taking any ibuprofen. Corticosteroid injections are also an option for just decreasing that inflammation at the joint, and they can provide a lot of pain relief. There is a shelf life to that pain relief because over time your body's going to metabolize the cortisone in the joint, but it can absolutely help. Last resort is always surgery. I think that always exhaust all your conservative treatment first. But surgery is absolutely an option when the pain is significant. And so this patient of mine basically had arthritis of the big toe joint, went through all of the conservative treatment and ultimately opted for surgery where they have a fusion of the big toe joint, and that's why there's a plate and screw holding the bones together. And so there's different options depending where the arthritis is in the foot. And as we can see, there's a lot of joints in the foot, and you can get arthritis in any of these joints. So really, the treatment and the surgery is dictated by the joint that is involved. All right, so jumping into tendinitis. So tendinitis is essentially an overuse or repetitive stress injury to one of the tendons in the foot and ankle. Achilles tendinitis, posterior tibial tendinitis, which is essentially on the inside or the arch of your foot. There's extensor tendinitis. So you can get tendinitis basically in all 4 areas of the foot and ankle, and it typically is when there's an overuse injury. We see an overuse injury when there's maybe a deformity or compensation. Sometimes I see Achilles tendinitis after a total knee replacement because maybe it's compensation of how you're walking after a total knee replacement, or tightness because you haven't been able to extend your knee fully after a total knee replacement. So yes, we work in silos of maybe just the foot and ankle, but I think ultimately it works all the way up. It's connected to your knees and hips, and so biomechanically we have to look at it all. But overall, for tendinitis, we treat it with anti-inflammatories, which are NSAIDs, and the goal is to strengthen and support the tendon. So decrease the overuse injury while also strengthen it. And that's what physical therapy, kind of targeted exercises to strengthen that tendon, that is the goal of treatment. And moreover, a flat foot deformity. So a lot of us, we've seen, maybe we are more of a flat foot type. We were all born with a different bone structure. It's hereditary. Some of us have more of a flat foot and some of us have more of a higher arch. With either end of the spectrum, we can see overuse injuries or tendinitis with either a flat foot or a higher arch. With a flat foot deformity, it basically increases the stress of all the soft tissues along the inside of your arch as well as along the inside of the ankle. And we call this hindfoot valgus. So you can see how the heel of the picture is kind of turning in and the arch is collapsing over. With that, we see kind of this chronic inflammation of the tendons and the ligaments, and sometimes even long-term arthritis to the joints because of that increased stress along the inside of the foot and ankle. The mainstay of conservative treatment for this is, once again, the goals are to support it so then there's less stress, decrease the inflammation, so whether that's anti-inflammatories or injections, or surgery to correct that deformity. The surgery is really dictated by the deformity. I mean, if it's an older patient with arthritis, then we're going to treat the arthritis that's underlying it. If it's more of just a flexible deformity, there's different types of surgical treatment that wouldn't involve the joint. All right, bunions and hammer toes. They plague so many of us. So a bunion, the medical term for it is hallux valgus deformity, but essentially it's this large bump on the inside of your big toe. And you notice the big toe starts to drift over, and then as that progresses, we see that the second toe starts to pop up. So the bottom image here kind of shows the progression of bunions. Bunions are hereditary. They are your bone structure. Shoes can aggravate it, but they truly aren't the cause of it. So just like being knock-kneed or bow-legged, that is your bone structure. Mostly someone in your family gave that to you. Bunions, similarly. And so it actually has to do with the alignment of the bone all the way back into kind of your arch. And so the treatment surgically for it is to address that deformity. But not everybody with a bunion needs surgery. Frankly, it comes down to the patient's pain that dictates that. But going back down to the bottom picture, you can kind of see the progression. So as we age, we know bunions can progress. And as that big toe kind of drifts over, it's all good, the second toe starts to pop up. And then over time, sometimes that second toe will kind of raise up and cross over the big toe, which is kind of the last picture here, where you kind of see the progression of the bunion and hammer toe. Procedures for this basically are to address the malalignment of the bone. conservative treatment for it is essentially to accommodate the deformity. So wide toe box shoes. You can absolutely try toe spacers and some of these contraptions you see kind of online and on TV, but I think the underlying thing is to know expectations. They are not going to correct your bunion. All they're going to do is maybe alleviate a pressure point from your shoe. They're going to maybe stop rubbing between the toes, but they are not going to change the bone position. Just like if I put a knee brace on, it's not going to change the position of my knee. It's just going to support it. And so that's just something to kind of be aware of with the conservative treatment with bunions and hammer toes. So on x-ray, bunions basically look like this. And the deformity, what I was trying to say earlier, is really back here, where all the way back to the joint, because the alignment of this joint is, this metatarsal is drift over, and then the toe drifts over the opposite direction. I think bunions had a bad rep for surgery, because about 30 years ago, we were addressing them wrong. Surgeons were going in and essentially just taking off that piece of bone. And that doesn't really address the underlying deformity, so they just came back. Now we know this, and so all of the surgical treatment is really to address the angle of this bone. So either you address it at this level or this level by realigning the bone. A lot of my patients come in and say, well, it looks terrible. When do I need surgery? I'm not the one to tell you when you need surgery. Frankly, you will tell the surgeon when you need surgery. A lot of people have a severe bunion, but maybe it doesn't bother them because they can accommodate it. Truly, a bunion should be fixed surgically only when it's stopping you from doing everything you want to do, and it should be dictated by the pain. So here's just an idea of kind of the difference pre and post-op, but it's still foot surgery, a lot of hardware in there. But you can see the alignment of the whole foot is now different. And to address it, it's not a quick fix. It's still, the recovery is a good 6 weeks of really being immobilized, because bone takes 6 to 8 weeks to heal. And so that's why you truly need to be immobilized for about just six weeks. That doesn't mean that you're not walking, but at least you're in a boot or something supportive to allow the bone to heal post-operatively. And so that's a pre and post-op, just to see the difference of realigning and then also kind of what's going on inside the foot surgically. All right, corns and calluses. Corns and calluses are basically a hardened skin which occurs due to increased area of pressure. We see them a lot with bunions and hammer toes. Because of the deformity, it's rubbing on the shoe, it increases a pressure point, and then you develop these corns and calluses. You can trim them, you can shave them, but they're going to keep coming back unless you address the underlying deformity or offload them in some way. The issue comes along if those corns and calluses continue and they almost can ulcerate or blister underneath them. And then you hear about ulcerations, and we don't want any kind of ulcers to the foot, because then it can increase the risk of infection. The biggest treatment for corns and calluses are making sure that they're kind of pared down. You can do this on your own just using cream and a pumice stone. You can also offload it using pads and making sure that your shoes fit properly, as well as they're really well cushioned. Any extra cushion will kind of decrease this, especially with hammer toes. Another reason we develop hammer toes is actually because of our balance. So if our balance is off, or if we have neuropathy, as our center of gravity kind of comes forward because of our balance is off, our toes start to grip. And over time, that gripping occurs, so our toes actually will grip and continue to be gripped, because the tendons underneath the foot are kind of stronger than the extensor tendons on the top of the foot. And over time, when you continue to do that, that deformity will almost become rigid. And then the toe literally sits like this all the time. And so if you don't have the right shoe, or if you're wearing like a dress shoe that might not be as accommodative, it's rubbing, and then you get a callus, and then you can get a sore. And so that's a lot of times what I'm trying to describe kind of with patients is maybe you just have to be an open-toed shoe or really accommodate the hammer toe. But unfortunately, once it becomes a rigid deformity, it's at the bone level, and the only way to straighten the toe is fixing the bone, which is surgery. So briefly, age-related bone changes. Other things that I see in clinic a lot with my patients who are becoming older is decreased bone density. So patient comes in with swelling of their foot, they have some achy, throbbing pain, and then it became sharp all of a sudden. They were starting a new workout regimen, but also was just diagnosed with osteoporosis, and I see a lot of stress fractures. And so I've also had some patients come in with this and has not had a DEXA scan and been diagnosed with osteoporosis, but then got them diagnosed with it because we can see it in the foot before anywhere else too. And so stress fractures absolutely are kind of a window into our endocrine system and understanding if our bone density has decreased. What can you do for that? Stress of the bone actually helps. So the more you walk, the more weight you actually put on our bones, the bones become stronger. It's why our astronauts up in space actually, they have more brittle bones when they come back because they don't have gravity on them. And so don't overdo exercise. I don't think going out and doing 50 jumping jacks is great, but walking is awesome. Like the more you're up moving around, the stronger your bones will stay. Maintain good bone health, so make sure your endocrine levels are okay. Women, we're more at risk for osteoporosis as we age because our estrogen levels are dropping. As our estrogen levels drop, throws off our endocrine system, so our bone health actually can change. Vitamin D, we live in New England, most of us are vitamin D deficient. And so you might have to supplement your vitamin D because that's good for your bone health. So other age-related health problems that I see in foot and ankle are diabetes, gout, peripheral arterial disease, as well as varicose veins and heart failure. So if you're having a lot of lower extremity edema, absolutely can be linked to kidney function and your heart. And so sometimes if our legs are very swollen, that can absolutely be a sign of something else going on, and so that's when I would absolutely recommend seeing your primary care. Another risk or another factor with lower extremity edema is a blood clot. So there's different reasons we can get blood clots. It can just be sedentary, it can be smoking, estrogen. It can also be cancer is a risk for increased clotting. So I've actually seen patients who didn't know they had cancer but had a blood clot in their leg that we saw. And so that's just another window kind of into overall health that we see in the foot and ankle. Varicose veins. So if you have varicose veins and you notice a lot of swelling or discoloration to the legs, it's important to address them because they can kind of worsen into varicosities or venous insufficiency. Okay, and we'll kind of touch on that. So diabetes. The problem with type 2 diabetes is over time, if your A1C, which is your average 3-month blood sugar, if that continues to be elevated, it will affect your nervous system. And typically it affects the nerves of your feet as well as the nerves to the eyes. So if you are type 2 diabetic and you see a podiatrist, I don't know, every 6 months to a year, and your eye doctor every year, it's because they really are checking to make sure that your nerves are functioning. The issue we see with neuropathy is basically your nerves are no longer functioning to your feet. So when you have a sore, or even if you stepped on something sharp, if your nail ingrew into your skin, you might not notice. Pain is a normal sensation, it's a protective sensation, and if we don't have pain at the bottom of the feet, we might not know when something's wrong. Not everyone is examining their feet every day because we've relied on pain as being our way to check up on something for our whole lifetime. And with diabetes, that changes that norm. And so I've had patients come in with sores on their feet because there was a nail in their shoe and they never knew. So neuropathy can be so significant where you have really no pain sensation. It can also be as minor as you can feel, but also have almost this neuropathic pain where you're getting numbness, burning, tingling. It typically is worse at night. And diabetes, because it is so prevalent in our population, is one of the major causes for neuropathy that we see in clinic. And so The problem with this also is with neuropathy, our balance is off. So those digital deformities I was talking about with the hammer toe or having a different gait because of our balance being off neuropathy also increases pressure points to the bottom of our feet, which can then develop into calluses and further ulcerate. And that's when you hear about people having limb salvage or infections or amputations because of diabetes. And it really is all linked to this neuropathy. So, more on peripheral neuropathy. The symptoms are essentially increased falls, so loss of balance, trouble sleeping because of the pain in our feet, hypersensitivity to touch. So it sometimes has not progressed all the way to loss of sensation. It could be even this hypersensitivity or pain that you feel at night. It can also happen during the day, but typically it affects people when they're trying to fall asleep. Tingling, numbness feeling, and peripheral neuropathy is not only caused by diabetes. Heavy hitters, we have seen it in alcohol use disorder, vitamin and nutrient deficiencies, as well as chemotherapy. And there's a whole host of others. These are kind of the major heavy hitters we see, but neuropathy can be caused by a lot. And when I say chemotherapy, it also means just toxins. Chemotherapy is a toxin, so a lot of patients have had some type of chemotherapy. The other thing to know about neuropathy and nerves in general, they are slow to react. So I have had patients who might have had maybe an alcohol use disorder 5 years ago, have had 5 years of sobriety, and now are developing neuropathy or neuropathic symptoms. It's taken kind of a couple years to develop these symptoms because nerves are pretty slow to react. So something to be aware of, it's not always instantaneous. Similar to chemotherapy, I've had patients go through 6 months of chemotherapy, but their nerve symptoms or neuropathy didn't start maybe till after. So diving into peripheral vascular disease. So our arteries, our heart pumps the blood, our arteries bring the blood to all of our extremities, and our veins bring the blood back. So the arteries basically are our plumbing system. If those arteries are blocked, then we have decreased blood flow to our feet. So if your feet have discoloration, if they are cooler, it doesn't always mean peripheral arterial disease, but typically we see it with arterial disease, typically we see effects in the foot. So because it's the longest or distance, we usually see kind of changes to the toes or even the heel, depending on where that blockage is in the arteries going down the leg, even the arms, but typically we see it more on the foot just because it's the farthest away from the heart. With this, there's a decreased ability to heal. So if there's sores or even fissures, and people are saying that they can't heal them, it's sometimes because the blood flow isn't there. If the blood flow isn't there, the nutrients are going to the area to be able to heal it. I think I am one of the probably fastest people to get most of my patients in to see vascular. We just refer a lot of our patients to vascular because the first place peripheral vascular disease shows up is in the foot. So diving back into varicose veins and venous insufficiency. So varicose veins are basically our veins use valves and the muscles around them to bring the blood flow from our feet back up to the heart, which is the pump. Okay, they basically use valves, like a valve system, to try to push that blood flow up, as well as the muscles. So actually, the more you use your muscles, your calf muscle, it helps get that blood flow back to the heart. But this is why when our veins, kind of those valves, don't work as well, they kind of engorge. This is hereditary too. If you knew your mother or your parents had really bad varicose veins, you might be more apt to have them. We see them more in women, especially after childbirth. Our blood volume doubles basically during pregnancy. And so having so much more blood in our system, that volume, basically sometimes you'll get varicose veins after pregnancy and then they kind of stay with you with life. And so the problem with varicose veins is if those valves don't work and they continue to get larger, the veins continue to kind of fill up with blood, and that blood sits in your leg, what can happen is actually the iron in the blood can seep out and we can get skin changes. And sometimes you'll notice the other than the leg just being swollen, it'll be kind of brown or discolored, and even to the point where the fluid has to go somewhere, so you can end up with ulcerations or venous ulcers. And truly the number one treatment for this is to not get to the ulceration and use compression socks. Compression socks are great. They're basically just helping those veins get the fluid back up to the heart, and the heart can then pump the fluid back around your body. So things to look for basically are edema, which is swelling of the lower leg, skin discoloration, if you notice kind of darker splotches along the anterior kind of front of your shin. If your skin feels like it's weeping or pitting, like you can put your thumb into the leg, and ulceration, as I said. So plantar fasciitis, essentially our fascia is like saran wrap in our body. It's this thick white band, and our plantar fascia is named where it's just a band along the bottom of our foot, but in reality it connects with our Achilles, our calf muscle, our hamstring, and goes all the way up the back of our leg. So we see plantar fasciitis, which is essentially inflammation of that plantar fascia, and it's also the most common reason we get heel pain. And the major factor kind of causing plantar fasciitis is usually tension. So tightness along our hamstring, our calf, can result in plantar fasciitis. The other half of plantar fasciitis is basically inflammation. So it can plague people where you feel fine, and then maybe you do a little bit more activity, and then the pain comes back the next day. And usually it's because the inflammation increases, but also the tension increases. Plantar fasciitis also typically affects people first thing in the morning, and it's usually when we're the tightest. We've slept all night, we're tight, and so that first step out of bed, you feel the heel pain, but the more you move your muscles, it dissipates. And so really the mainstay of treatment for plantar fasciitis really should be addressing the tension, whether it's from your hamstring, your calf, it's probably around the whole back of the leg, as well as stretching of the foot. Addressing any type of inflammation, whether that's just ice, as I said, anti-inflammatories, or cortisone injections are options. And then, yes, there's an element of support. Do I think a shoe or an orthotic is going to solve everyone's plantar fasciitis? Probably not, but could it help? Yes. Plantar fasciitis, I think, is so common and has been kind of marketed too because it's so common. So if you go online, you're going to get like inundated with all these ads, and it's like, try this, it's going to solve it. But because so many people develop it because of so many factors, you have to address all of those factors to truly get it to go away. All right. Exercising smarter. I can't say it enough. I think shoe wear, I'm not here to tell you what type of shoes, but I do think wearing a supportive shoe can be very helpful. I've had so many patients go, and especially this time of year, like, I'm gonna go mow my lawn, but I put on my worst pair of sneakers because I don't want to ruin my nice ones. And it's actually the most activity they've done in a while, and they end up with injuries, right? So your feet should be protected, but they should also be supported. And so the other part of this is strengthen and stretch. So strengthen is great for your bone health, but also stretching, I think, is really, being limber can help with injuries, but also can help with any kind of tendonitis. A lot of symptoms I see are because of tension, essentially, like tightness along our Achilles tendon and hamstring. And so being flexible can absolutely help. Maybe skip the high impact exercises and work on more slow calisthenics, strengthening exercises. We don't all need to be running the Boston Marathon, but I think walking is amazing, right? So the more you walk, the better it is for your bone health, your cardiovascular health, and I think that's the goal here. I'm saying go for yoga. I know a couple of my patients actually in the area, I think there's a Tai Chi class through maybe Quincy or maybe it's Weymouth, but they rave highly about it. All right, as I said, basically your feet it really shows your health. So try not to skimp on them. I think check them out. They're going to give you a window of your overall health. If you notice differences to your foot and your leg, like skin changes, swelling, discoloration, absolutely, I think it's something to talk to your primary care about so you can be referred to the right kind of physician, because a lot of things do manifest in the foot and give us an insight of something else going on. All right, well, thank you. This is my two kids, I have a husband too. He was the one taking the picture.